Hi there, everyone. My name is Zuhair, and this is the third session in the Mind the Bleep Psych Final series. If you would remember, in the previous two sessions, we went through psychiatric emergencies, we went through depression and anxiety, and this is another very common psychiatric presentation that you'll see a lot in your placement, and it will appear a lot in exams: schizophrenia and bipolar disorder. So let's get started. Okay, so again, UK MLA ping does not necessarily reflect how conditions will present in real life, but this talk will cover schizophrenia, psychosis, and bipolar disorder, and is mapped to the presentations that are on the left-hand side as well. Okay, the first question I have, just to kick it off, is schizophrenia versus psychosis, right? So these are two things which are very, very often confused and very often conflated. Does anyone know what the difference is? Can anyone put in the chat what the difference is, or what anyone thinks are some ways of telling the difference between these two? Or is there a difference? So psychosis is that's right. Yeah, psychosis is a broader sort of label, and it basically is more. It's an umbrella term for a lot of presentations, which we'll see in the next slide. But before I get into that, there's a poll that I want to put up. So, a 20-year-old woman is brought into the emergency department by the police after being arrested in a local bar for odd and aggressive behavior. While taking a history, she tells you that she can't understand why she has been arrested, as she was just celebrating the fact that she has recently figured out how to solve world hunger and she wants to share it with everyone. You struggle to keep up with her pace of speech, and throughout the consultation, she is aggressive and at times sexually inappropriate. An initial drug screen is clear, and her bloods are unremarkable. So, what would the most likely diagnosis be in this case? And I'm going to put the poll up over here, if you can all see that. Okay, it seems like everyone has actually got the right answer, which is very nice. So the key things in this history is the age, the odd and aggressive behavior, the pace of speech, and the disinhibition, which is manifests in this case as sexual inappropriateness. So personality disorder is a common differential, but why is it not personality disorder? Because this is a new onset thing. Personality disorders are usually quite permanent. Why is it not alcohol intoxication? There's the drug screen was clear. The same with drug-induced psychosis. And bipolar disorder, it may be bipolar disorder, but at this time, you have no evidence of a depressive episode followed by the manic episode that this patient is having here. Okay, so psychosis is essentially, so this is the distinction between psychosis and schizophrenia. Psychosis is a failure to differentiate between reality and imagination. or this is a good definition. It's quite comprehensive of all the features and all the conditions that fit under it. Psychosis is a constellation of symptoms which appear in many different conditions, and that includes the symptoms are three main ones, which is hallucinations, delusions, and thought disorganization, and we'll talk more about those later. And these features result in a person being agitated, depressed, and they can result in all of these things. And self-harm is one that we obviously would watch out for and you would risk assess. As for conditions which can present with psychotic features, schizophrenia is a very common one. Bipolar disorder as well. Puerperal psychosis, which is just after birth, after a mother gives birth. Brief psychotic disorder is psychosis lasting less than 1 month, and this is also common in some neurological disorders like Parkinson's. And one that is really commonly asked in exams actually is, for example, a woman has been taking 30 milligrams of prednisolone, and she is seeing, she is hearing things which aren't there, she's seeing things which aren't there, and her speech is incoherent, is very often related to corticosteroids. And it's a very common exam question as well. Also, cannabis. I think I did it on the previous question on the previous webinar, and a lot of people got that right as to the connection between cannabis and psychosis. Okay. So just a question here, which is, let me just get this up. 23-year-old man presents with a 6-month history of firmly believing that his neighbors are spying on him through hidden cameras. He has no evidence to support this belief, but he is convinced it is true. He has confronted his neighbors several times and has even changed his living arrangements to avoid being watched. Despite this belief, he functions well in daily life, denies any hallucinations, mood disturbances, or other psychiatric symptoms. So in this case, this is a bit of a harder question. Let me put the poll up here. I've purposely made it quite a bit harder. Let's see if we can, how many people will get this one right. Okay, we got schizoid personality disorder. This is good. Okay. Okay. Okay, great. So we've got 50% have gone for schizoid personality disorder. 25% have gone for schizophrenia. 25% have gone for delusional disorder. And this is quite a hard question, and I don't think they will give you a question this hard, but it's still very worth knowing what is going on with regards to the important points and why it's the answer it is. So 6-month history. So it has a start date. It's not a permanent fixture of their personality, right? If a thing has a 6-month date, yes, it is enduring. Yes, it is long-standing, but it's not. You couldn't consider a personality disorder. Personality disorder is typically diagnosed in adolescent time, and it's got features which carry on through them throughout their life. It's very difficult to diagnose personality disorders unless you have multiple follow-ups with the patient throughout a long period of time. So the 6-month history would point away from personality disorders, as with the fact that this talk is not about personality disorders and is about schizophrenia. So spying. So what spying is a persecutory delusion, as he has no evidence to support that belief. So it wouldn't be generalized anxiety disorder, because that usually doesn't have persecutory delusions, although it can, but it usually has a wide range of different things a person's anxious about, including finances, including different sorts of stress, which doesn't follow the pattern here. And there's no sort of anxiety being mentioned, or though 6-month history is quite typical of the questions on GAD, because that also has a 6-month history. Okay, so change his living arrangements, but he functions well. Okay, this is a very pertinent point as well. So if someone functions well, it's a good way of delineating if it's severe or non-severe. So if a person functions day to day, but he still has these beliefs, then you can say it's a less severe presentation. So that's key to pick up as well. Hallucinations, mood disturbances are two things, and why it's not schizophrenia is what we're going to find out in the next slide, but it's actually something called delusional disorder. And so just going on to the next slide. And delusional disorder is it's when a person just presents with the delusion aspect of usually associated with psychosis or schizophrenia, and it's just delusions, and it's delusions that's been put over a prolonged time. They're well functioning. They're functioning well. Okay, and also no negative symptoms, and we'll find out what that means in the next slide as well. So these are the symptoms of schizophrenia. So schizophrenia is a condition which is quite interesting, because it's culturally, we often say that psychiatric diseases are, they are products of your cultural environment, but schizophrenia is something which is culturally widespread. It's a global phenomenon, which points to a biological cause. So it has a prodrome in all its different manifestations. It has a prodrome usually, and that'll be a cognitive decline, and people will go into that. They'll go away from their friends, and they'll go away from their family, and they'll become a bit more isolated, and they'll become a bit suspicious, have certain not to the degree maybe of persecutory delusions in the prodrome phase, but they'll develop certain suspicions, and they might get less sleep as well. Now, there's something called Schneider's first rank symptoms that is very key to remember in schizophrenia, and this is really what's going to be the mainstay of questions on schizophrenia in terms of the symptomatology. So it's 4 things that you need to remember. It's persistent auditory hallucinations. So so for example, hearing something that's not there. For example, hearing people talk to them that's not there. Persistent delusions. There's 2 main types of delusions. The first type is the one we saw previously, where someone believes that the government or someone is spying on them, where there's no evidence for that. And the second one, or spying, or wants to kill them, or wants to attack them, wants to harm them in any way. And the second one is delusions of grandeur, or grandiose delusions. A really good way of ascertaining that in a patient is asking, do you believe you're famous or related to anyone famous? Because oftentimes, especially in the UK context, a lot of this manifests as, yes, I'm related to the Queen, or I'm related to the King now, or I'm related to this celebrity, that celebrity, and that's usually how that presents. So that's a really good question to ask to differentiate. And The third thing is thought disorder. So this is what you'll typically pick up in OSCEs and MSc situation. When you're talking to the patient, they might have aspects of these different thought disorders, which in an OSCE session later perhaps we'll get into. But tangentiality, like not getting to the central point, circumstantial, not getting to a certain point and going around the houses before you come back to the main topic. Circumstantiality, not actually going back to the main point at all and just continuing circling on your own little train of thought. Pressured speech is speaking very fast and sort of like you have to get the words out. Clang association is rhyming, and there are a whole list of these potential, but the really pertinent ones to know is tangentiality, pressured speech, and clang association. I think that those are three really common ones. Okay, this last of the Schneider's first rank symptoms is, and these are symptoms which are most common in schizophrenia and diagnostic of schizophrenia, is passivity phenomena. So this is really easily ascertained by the question, do you believe someone is controlling your thoughts or putting thoughts inside of your head or taking thoughts outside of your head? So there's three aspects to that. And the first one is thought insertion. Someone's putting thoughts into your head. Thought withdrawal. Someone's taking thoughts out of your head. And the third one is, you believe your actions are controlled by another. Often this is like, I think the government's controlling my actions through an implanted chip in my brain, or this is what you hear most commonly, or at least I've heard most commonly when I've been around these patients. Now, in order to diagnose schizophrenia, you need one of Schneider's first rank symptoms. You need one of Schneider's first rank symptoms and at least two symptoms that can be from the first rank symptoms or the other symptoms, which include negative symptoms. And they're called negative because they're kind of like losing a part of or decrease in function. So a flat affect, you're losing your, vocal range, speaking less or speaking not at all, paucity of speech or allogia, anhedonia, not enjoying things anymore. These are all seen as negative, and losing motivation. That's avolition, is loss of motivation. So these things are all negative things, like which can be seen as kind of loss of function. And just this is another one of the ICD-10 symptoms, which is like disorganized behavior, which is a sort of more vague, a vague symptom, but I guess it's connected to that, severity. Is it impairing your your day-to-day functioning in your life? On the previous question, is kind of connected to that. Can you pursue your goals without, being too afraid of someone persecuting you or your hallucinations, etc. And catatonia is, being in a catatonic state. So it's two of these symptoms, one of which must come from the first rank symptoms over the course of 1 month. And the four to really know are the first rank symptoms. And the worse the prodrome phase, the worse the prognostic. The worse the prognostic, the worse the prognosis, basically. So schizophrenia, one thing you need to know for the exams is that it has a strong genetic element, which is what I pointed to previously with the fact that it's one of the few psychiatric conditions that is a widespread global and is across all cultures as well, and all times that we can discern. So a monozygotic twin has a 50% chance of, if one twin has it, then the other twin has a 50% chance, and a dizygotic twin has a 15% chance. And this is a really, really good way of working out if something is genetic. So there's a strong genetic risk factor. And the second thing is cannabis use, which is a risk factor 1.7, 1.7 relative risk ratio, I think. Pregnancy, because you can develop, an element of puerperal psychosis after pregnancy or after birth, which is strongly associated with a development of schizophrenia after that. It's also Afro-Caribbean ethnicities in the UK have a higher rate of schizophrenia, and now this is most likely a cultural phenomena, which is because of in the literature there's many reasons given for this, but the most compelling reason I think is because the low socioeconomic class, which is independently a risk factor and therefore is confounded by Afro-Caribbean ethnicity in these studies. So there's certain negative, and generally speaking, all minorities in any countries have increased rates of schizophrenia, and that's usually mediated by a low socioeconomic class. But I think there might also be an element of you know majority versus minority politics in that. So the two things that you're going to get asked about in exams is risk factors, especially genetics, and prognostic factors. Okay, this patient comes in, they have for the last 4 years they've been having a very, very slow sort of a descent into having more and more hallucinations, more and more delusions, etc. What part of this history is the most worst prognostic indication of their schizophrenia? And that would be gradual onset. Gradual onset is something that's associated with schizophrenia, which is going to go more and more. It's going to get worse and worse. Whereas having a very abrupt onset, very quick onset, is a sign that is caused by something in the acute phase, and when that stressor is removed or when that trigger is removed, then it's easier to go back to normality, as it were. So again, family history, we talked about genetics, and low IQ. And low IQ, I don't think IQ is a good measurement of anything, but in the literature and for exams, it's good to know that a low IQ is associated with worst outcomes in schizophrenia. And I think that would be secondary to the cognitive decline that you see in the prodrome period, and obviously people who have they have less decline, they can have more sort of insight into their symptoms, and therefore it's less bad. It's less debilitating for them. Okay, now this is the mainstay of the questions. Okay, so the management of schizophrenia is usually with either typical or atypical antipsychotics. Okay, and the mechanism of action is very complex, and I'm not going to fully touch on that. I'll give a brief summary, just so it makes sense. So just so you can connect the pathophysiology to the side effects and the functioning, and make it make sense in your for you. But the mainstay of treatment for schizophrenia is atypical antipsychotics, is drugs like olanzapine, risperidone, aripiprazole, etc. And the receptors that they work on, that you should be aware of, is the serotonin receptors and D2 receptors, just like which is the dopamine 2 receptor. And with typical antipsychotics, one of the real critical side effects that I'm sure you all know about is the extrapyramidal side effects. So these are things like tardive dyskinesia, acute dystonia, and which we'll get into in the next slide. But atypicals have a lower incidence of this, then therefore, and these are really like seen as the really bad side effects for these medications. So they have a lower incidence, so they're more preferred, and they are quite effective as well. They have an increased incidence, however, of metabolic disorder, so dyslipidemia, weight gain, rise in prolactin, and just and central obesity. And one thing to note is that rise in prolactin can cause galactorrhea, which is quite a common condition with people who are on long-term atypical antipsychotics. Now, going back to typical antipsychotics, the D2 receptor agonists, which basically means they dampen, replace the dopamine receptor in the in the basal ganglia, and in many different parts of the brain as well, which control they control different aspects of neurological functioning, including the direct and the indirect pathways, movement pathways, and this connects with the extrapyramidal side effects, which I'll talk about later as well. Okay, so one thing to note here is that there's a very, very clear sort of side effect profile difference between atypical antipsychotics. Aripiprazole, safest, it's a partial D2 agonist. It's not a full antagonist, so it doesn't have the same efficacy, but it also doesn't have the same level of side effects. So it's a really good, and it doesn't cause the same amount of prolactin rise. And with people who are quite sensitive to that for whatever reason, they would do better on aripiprazole, which is a common question that's asked, which is the atypical antipsychotic with the lowest side effects. Whereas you have a drug on the other end, like clozapine, which is only used in refractory psychosis, and is only used if you've tried multiple other drugs and they haven't worked. Usually 2 other drugs that haven't worked, and then you chose clozapine. And the reason why clozapine is not used first line, although it's very effective, is because it has a very, very high side effect burden. And of the side effects, granulocytosis is really a key one, which is a low neutrophil level, which can precipitate all sorts of septic events, and it can, reduce your ability to withstand immune disruptions and immune insults. So clozapine, if it's asked in a question, okay, this drug's clozapine, what do you have to be aware of with this drug, or what should a patient who's taking clozapine be aware of? It's always FBC, check the neutrophils, because that's because granulocytosis is a very serious side effect. Okay, so extrapyramidal side effects of these typical antipsychotics, and also less in atypical antipsychotics. Haloperidol being the prime drug causing these. Acute dystonia. So acute dystonia is when different muscles in your body, they can remain fixed in certain positions. So torticollis is a fixed neck. When you're in a certain position, when your neck is fixed in a certain position and is resistant to moving, moving away from that position. And as you can imagine, this is quite a painful, a very, very painful condition, and oligogyric crises, which is a fixed upward gaze when someone's fixed looking upwards. And this is often given if you have picture exams. This picture, and okay, what is going on here is acute dystonia in the form of oculogyric crisis, and procyclidine and different drugs treat that, which we'll get on to in the next slide. So akathisia is another side effect that's worth knowing. It's just a severe restlessness, and it's when a person can't remain still, and that's to do with the D2 receptor, which inhibits the indirect pathway, and the different pathways. You've got the nigrostriatal pathway, but the main thing to take away from this is that because it acts on D2 receptors, it's hard. It inhibits the inhibition of movement. So it basically you can't. It's very difficult to stop moving. Yeah, the dopamine receptors are quite complex. And as much as I would like to go into it, I really think it doesn't have any. It has really debatable relevance for final exams in terms of priorities. So I won't go into it here. Now, tardive dyskinesia is, it's abnormal repeated movements of the jaw and face, and this is often seen in repeated chewing motions and repeated jaw motions. And if you type in videos of tardive dyskinesia, it's very unique, and you'll get a sense of that if you if you look at that. One sec. Excuse me. So these side effects, they go from very acute onset in acute dystonia to more prolonged, very long-term onset, where you have to be taking the drug for a number of months or years. Excuse me. Okay. So neuroleptic malignant syndrome is a very common condition that's asked about in schizophrenia, and it has a mortality of 10%. Excuse me, I'm just going to get a drink of water. Sorry about that. Okay, so neuroleptic malignant syndrome is is very common in schizophrenia, in terms of the overall numbers as opposed to a lot of other disorders. It's a condition which is quite serious, and it carries a very high mortality burden, and so it's definitely something to watch out for, and it's something which is asked very, very often in exam. It's blocking the D2 receptor can cause increase in glutamate release, which can cause glutamate can be neurotoxic at high levels, and that causes all sorts of symptoms, including fever, very rigid muscles, changes in your blood, wild fluctuations in your blood pressure, and postural drops, etc., and also confusion, acute confusion, and delirium. Because of the muscle rigidity, you very, very often see raised creatine kinase, and it can cause AKIs and rhabdomyolysis as well. So the management for this is very simple: it's IV fluids, and You can also give dantrolene and bromocriptine, which is a dopamine antagonist, a dopamine agonist, but it's not very often given. IV fluids and dantrolene is the mainstay of this neuroleptic malignant syndrome, and you'll often see it on patients who have been, just increase their dose, or they've taken or they're taking double their dose accidentally, or they've switched to a new form of medication. So, for example, from depot injection, they've switched to a regular oral tablets. Okay, so that's schizophrenia in a nutshell, and now we'll talk about bipolar disorder. So, bipolar disorder is typified by a cycle. It's a cycle of mania and depression, or hypomania and depression. Mania and hypomania, knowing the distinction between them is very key, because the bipolar disorder has two different types, and the first type is associated with mania, and the second type with hypomania. So mania is it's for greater than a week, you have a severe impairment of functioning, and it's associated with hallucinations, delusions, these psychotic features that we talked about previously. Okay, and the second type is hypomania, and that typically has milder symptoms. Doesn't impair your functioning so much. You can often, people still they still their job while having hypomanic episodes, and it's associated with elation, feelings of good mood, but not excessively good mood, and it's not associated with psychosis. If it's psychosis, it's not hypomania. It's going to be mania. Now, I don't think you need to know, but it's worth just bearing in mind for differentials that cyclothymic is rapid switching between these two. Now, as for symptoms of mania and hypomania, I'm sure when we think of mania, when we think of hypomania, just in general life, we can think of elevated mood, being really energetic, having lots of ideas, being not able to stick with one idea for a long time, just keep on going from one to one to one, from one to the next one to the next one, and speaking really fast, not being able to sleep. These are things which are quite they're quite well-known symptoms of mania. They're quite symptoms that would be familiar to the average person as well. And there are some symptoms of depression which we went into in the previous talk, which was anhedonia and low mood, etc. But the key difference to know in bipolar disorder is mania versus hypomania, and knowing, okay, is this presentation mania or is this presentation hypomania? And therefore, is it type 1? Is it mania? Has the patient got symptoms of psychosis, in which case it'll often be type 1, or have they not? Is it milder? Is it lasting less than 7 days? And then it's going to be hypomania. Okay. So this is a really good way to visualize a graph I found online. You can see that the mood is less sort of ecstatic in hypomania, but it's still elevated, and cyclothymic is kind of a rapid switching between the two. Yeah. Okay. So the acute management of bipolar disorder. Now, before jumping to lithium, which I'm sure we're all thinking bipolar disorder, lithium, in the acute phase of mania, often the question is, what a patient has presented, with features of mania. They are having pressured speech, they are full of energy, etc. Previously, they were depressed and they were taking fluoxetine. What's the first stage of management? Is it to start antipsychotics? Is it to do X or Y, or is it to stop the existing antidepressants? And that always takes priority. Tapering the existing antidepressants takes priority over starting new antipsychotics. Okay, so make sure you taper the existing antidepressants and don't stop them cold turkey, because that can give all sorts of shocks, all sorts of symptoms like shocks and even worse, mood changes. Now, in the acute depression phase of a known bipolar disorder, you would give both olanzapine and fluoxetine is first line to give. Both olanzapine and fluoxetine. Why? Because if you just gave fluoxetine for depression, then as we saw previously, when it goes back into mania, then it can induce, it can perpetuate that. It can speed up the switching between those two. So that's why olanzapine is given to blunt that effect. Now, a drug you really need to know about is lithium. Lithium is a very important drug, not only for finals for the PSA, and even as a F1 myself, it's something that comes up very often with psychiatric patients, prescribing lithium, being aware of the side effects of lithium, interactions of lithium, etc., and the routine management of lithium as well. So it has one of the narrowest therapeutic ranges of any psychiatric and of a lot of drugs. Even though 0.4 to 1 is the therapeutic range, the target range for most people is 0.6 to 0.8, which is very, very small. It's excreted through the kidneys, which gives it quite a long half-life, because it doesn't have its it only has that method of excretion, and it has a lot of side effects, and this is why lithium is quite infamous. This is what lithium is quite infamous for. You have some side effects which are common to many drugs, like gastrointestinal issues, but also nephrotoxic, because it's renally excreted. It can build up in the kidneys, and it can cause nephrogenic diabetes insipidus, as well as can cause AKI, and it can be nephrotoxic in other ways as well, which is on the next slide, I believe. And it can also, this is very worth knowing for exams, especially the derm section of the exam, is that it can trigger psoriasis. Now, with lithium, because it's a metal, it does have an effect on other, it has interactions with other biochemicals in the body. So hypercalcemia is one of the side effects, but also lithium itself exerts a hypokalemic effect on the heart, on the cardiac myocytes. And just as in hypokalemia, you can have, inversion of the T wave, flattening of the T wave, you can have bradycardia. Just as you can get these in bipolar disorder. And then you don't even have to be at a very high dose. You can be within the target range and still get these symptoms. So this is worth knowing. And it might be a question on ECG, this patient has come in with this, they are on lithium. What is the likely cause of these symptoms? And one option will be hypokalemia, and the other option will be lithium. So monitoring is often asked in a lot of different contexts with lithium. It can be post-dose. How long do you check the levels? That's 12 hours. These are just things you need to know. 12 hours post-dose, weekly until stable, then every 3 months as a baseline. As a baseline every 3 months. And if you change it, if you move up or down in that, then again, it goes back to weekly until stable. So 12 hours post-dose, weekly until stable, every 3 months. And then every 6 months, you do, you check the EGFR, you do a renal check, and you check the thyroids and the T4 and the TSH, just to make sure it doesn't have effects on that. And these are a lot of side effects. So there's a little mnemonic you can use to remember. Lithium. So it causes leukocytosis, it causes lethargy, insipidus, nephrogenic diabetes insipidus, which would have to check the osmolality and check that it doesn't change with, it doesn't present or any other, it doesn't, you have to do osmolality tests on that basically, and there's multiple phases of osmolality tests. This tremor that we talked about, T-wave changes, just like in hypokalemia. Also hypothyroidism, and with the H's, hypothyroidism. So obviously, if you're hypothyroid over a long period of time, your thyroid gland is going to get bigger and bigger and bigger. And in people in lithium, you can often see thyroid gland hypertrophy and hyperplasia. So hypercalcemia, and that can give the the stones, bones, groans, the typical hypercalcemia symptoms. Hyperparathyroidism as well, and weight gain. But the main ones that you need to remember are leukocytosis, nephrogenic diabetes insipidus, and hypothyroidism. Okay, but with lithium, you also have toxicity. So lithium toxicity is, as it's got a very narrow therapeutic range, it happens quite often actually, and it's really worth knowing about for exams. Also, if just generally, it does come up in exams, but it also is very worth knowing about in the acute setting as well, because knowing that, this patient's lithium levels are raised, this is what I can expect, is very useful. Now, certain things can exacerbate lithium toxicity or precipitate a lithium toxicity, because a dehydration can lead to an AKI that can worsen, that can cause less effective kidneys, which can cause higher lithium buildup in the kidneys, which can precipitate lithium toxicity as less is excreted. And also certain drugs can precipitate it, and these drugs are diuretics, ACE inhibitors, and angiotensin receptor blockers, which are all to do with the RAS system, which is also very intimately tied with the kidney function. Metronidazole and NSAIDs as well, which we know are nephrotoxic. So it's a lot of nephrotoxicity going on here, I think. That's a good way to think about it. So with lithium, you usually get a fine tremor. It's a fine tremor. It's perceptible, but it's very fine. If it's toxic, it'll exacerbate the symptoms. It's a dose-dependent tremor. So the higher the level, the worse the tremor will be. So you have a very coarse, a very noticeable tremor with high levels of lithium, and you get in terms of nerve symptoms, you get hyperreflexia, and it can also lead to seizures. Polyuria is a symptom as well, but it can also cause neurological symptoms. And often you have a patient who you can have a patient who comes in, they're more confused, they're on lithium, and for whatever reason, someone decides to increase their lithium level. Now that's completely the wrong thing to do. You need to check the lithium levels, and then you need to prescribe in relation to that. And it can also, in the worst circumstance, it can cause coma. Now, the management of this is very simple. It's just resus IV fluids. Let's drain the lithium out of your system. And of course, most of these cases occur in lithium toxicity when the patient is dehydrated. So IV fluids will help with that as well. Obviously, it's very severe, then you need to do renal replacement therapy, and hemodialysis is the go-to for that. Okay, are there any questions about what I've talked about so far? Are there any questions or anything you didn't really understand or you want more clarification on? We're all good? Well, that's good. In that case, thank you for listening, and I hope this was beneficial. And if you have any positive or negative feedback, please put it in the feedback. Please put it in the feedback section below. Thank you very much. Thank you. Oh, there's 2 Adeles in the chat. Nice. Okay, I'll stop talking now.